el, para que podamos interactuar posteriormente con el doctor Lee. Dr. Lee, let me introduce you to all of the members of the Mexican Society for Simulation in Health Sciences. Bueno, pues vamos a comenzar con la presentación de nuestro ponente del día de hoy. Tengo el gusto de presentar al doctor David Lee. El doctor Lee es médico del hospital de Guangzhou First People Hospital y participa activamente en los asuntos de educación a nivel departamental de su hospital. El doctor Lee, además de esto, es un educador certificado en simulación, CHSE, de la Society for Simulation in Healthcare. El doctor Lee tiene el honor de haber sido el primer educador certificado en simulación de China por parte de la SSH, así como también ser un instructor certificado en la educación de pacientes estandarizados y trabaja estrechamente en colaboración con el Centro Nacional de Exámenes Médicos para promover la participación de enfoques de simulación, pacientes estandarizados en exámenes nacionales de licencias médicas de China. El doctor Lee, además de eso, ha trabajado activamente como traductor de diferentes libros, entre ellos el libro de texto de Integración de la Simulación en la Atención Médica del profesor Adam Levine y de todos sus colegas. Además de esto, el doctor Lee cuenta con una capacitación y una certificación en Debriefing Assessment of Simulation in Healthcare, DASH, y Promoting Excellence for Reflective Learning in Simulation, PEARLS, que el doctor Lee ha hecho el favor de traducirlo incluso al idioma chino para su implementación en su país. Perdón, es muy extenso el currículum del doctor Lee y estoy tratando de hacer un resumen de su amplia experiencia con la que cuenta. Además de esto, el doctor Lee es un instructor certificado en simulación por el Centro de Simulación Médica de Boston y actualmente es secretario general del Departamento de Simulación de la Atención Médica de la Fundación Médica Wu Jiping, y que es una organización no gubernamental líder en el área de la medicina en China. Es miembro de la Society for Simulation in Healthcare, de la Hong Kong Society for Simulation in Healthcare y también es miembro activo de la Asociación de Educadores de Pacientes Estandarizados, ASPE, así como del Comité de Normas Prácticas y, además es asesor del Subcomité de Redes y Tecnología de Directores de Cursos de Habilidades Clínicas. Actualmente el doctor Lee también es traductor de la SSH para todos sus manuales y estándares que están actualmente vigentes. Pues vamos a darle la bienvenida. Dr. Lee, thank you very much for your time. I have just introduced you with the brief curriculum that you developed to me. You have a lot of experience. I know that we can learn a lot from you. So please, if you can share us your experience about what have you done with this COVID-19 in China using simulation, please?
Okay. Thank you, everyone, for coming here in your morning time. Well, actually, it's currently 11 o'clock in China, PM. And so I'll just start directly with our stuff. So actually, we started preparing for the COVID-19. At that time, we were calling that some kind of the new coronavirus or like unknown virus issue. So that's while I was still at the conference in IMSH conference in the States. So around that time, I've heard like news from my hospital as well as my colleagues that the situation is getting worse. So we were using the WeChat, so something similar to the WhatsApp to contact my friends and also my colleagues in the hospital. So at first we say that we have to get prepared for the stuff. So at that time we were only talking about those skill training, like the personal protective equipment, how to use the personal protective equipment stuff around that time. So I think around that time, so that's around like January to like late January, around 16 to the 24 something. So so we use the online platforms for me to develop like certain things to do and connect with my friends back in China for those PPE stuff, both in my hospital and some of those that's actually outside my hospital, but other hospitals in China. So at that time, we also know we have very limited knowledge regarding the virus. So protecting the healthcare workers or our colleagues is the primary goal for us. And later we heard that after I came back to China, we heard news that they are sending reinforcements to Wuhan, which actually is my hometown. So that, but we got certain days before we send different the so-called troops of doctors or physicians or nurses to Wuhan. So I made a proposal to my hospital leadership that we should gather them for training, not only for those personal protective stuff, but also certain skills they might be of use in the while they were or being sent to Wuhan. So that's what I mentioned in the editorial, that they might need to do more than just a hand hygiene, wear masks or donning and doffing of PPE, but also do, while they were equipped with personal protective stuff, they have to do like the patient, they have to do like tracheal intubation, or we should say the airway management, and also like probably the CPR. This is the most difficult part. I think that's the difficult part, because when we are in the PPE, the cover also stuff, it's very hard for them to provide quality CPR to the patients, and we are aware that not all of those hospitals have the machines for chest compression, so that's maybe I can just share maybe I can share my screen as the editorial, okay? First, so yes. So this part, like the airway management, and also like the team dynamics, I think that's also a difficult part initially, because we were extracting the hospitals. Hospitals in China are expecting physicians from different departments to come together to form these task forces to be sent to Wuhan for providing medical services. So team dynamics, they may not necessarily know each other pretty well, so they have to get prepared for everything even before that. So what we did also, like after after all those my colleagues went to Wuhan for that. After they received training for PPE, the airway management, and also the team dynamics, they were settled down in Wuhan, and they have to stay and get extra training for 1 more week before they actually enters the wards to take care of the patients, because the things we do here in Guangzhou is somewhat different from the things we do in the things they do in Wuhan. So they're being trained by they were being trained by the local faculties to get to know about the environment better, and try to provide like efficient healthcare to those patients. And also, not every hospital have the equipment of the ECMO stuff. But actually, our hospital is one of the hospitals that actually could provide ECMO. So we actually bring the ECMO machine. So my friends actually bring the ECMO machine to Wuhan. And before that, they also received training, both simulation and both lectures and ECMO trainings to or scenarios on ECMO. And because around that time, that's the Chinese New Year, and many of the students were actually away from the hospital. So we are not in we are not actually in like a full run of courses for the students. So we take advantage of that time, and we have like enough space and time for the healthcares to train in our sim centers. So that's one of the advantage we had around that time. So that's for the critical care part. So actually, we for the PPE stuff, the self-protection stuff, we try to provide the training to those that are in most need. Those people that actually are going to Wuhan are the priority, and like later we provide the people. We provide the training courses to those who are about to who are like in our so we actually we send different teams to Wuhan. So those who are going to be on call immediately will get trained first, and then we have those that I would consider as backup of the reinforcements to get trained later, like maybe 1 week later.
No,
100 teams, 100 something teams to Wuhan, and I think most of them are coming back gradually because the situation is getting better. And also after for the self-protective stuff, after we provide those to the to the actual personnel at work, we now start to shift to training those the residents in our hospitals, because they are currently working as like the major forces to work in the wards. So we are training them right now. We have finished the third year residents. We are moving gradually towards the second year residents now. So we will, because this virus thing prevent us from gathering with large group of people. So we only have like around 18 participants for per each course of the PBE. For those running of the scenarios, like the critical care scenarios, we only have like less than 8 people around the time. But we do allow the people to observe. We also take videos. But that's the observation. We really want those who would be sent to the front line to actually participate in the scenarios and receive and do debriefing afterwards. For the debrief, so normally we do debriefing with the structure debriefing, like the advocacy inquiries way to do that. But since the time is very limited, we only we do it in a rapid psychodeliberate practice manner. So in this way we can quickly make them adapt to the algorithms of taking care of the patients without wasting too much time on like the reflection. But actually we do encourage them to reflect on themselves because they are all experienced healthcare workers. And that's so that's for the intensive care part. We despite from that, we aside from that, we also had much experience doing simulations for for what we call the pre-assessment triage. So this is being done in the outpatient setting. And in China, we have the outpatient so that's like the clinic. That's like the clinic part of the healthcare services. But actually, almost all the large hospitals, they have the outpatient department, and they allow patients to come like walk-in patients, or they can take in the pre-registered patients. But so the outpatient area becomes a high risk for infection for the patients and healthcare workers. So in China, after the SARS in 2003, I think in the year 2005, the Ministry of Health has like developed the policy for every large hospital to have like the pre-assessment and triage mechanism to be implemented in the outpatient setting. So this is to try to triage those people that is being highly suspected as like being infectious, to have this disease to be sent to designated places or designated fever clinics or for that. So in your hospital, we have the fever clinic that's an isolated area to the outpatient. But for this COVID-19 situation, we also have a third, what we call the new fever clinic area in our hospital. So all those that is being considered as suspected COVID-19 positive patients, we use the triage system to send them to the new facility. But we maintain those with low risk of COVID-19, but still have fever or other stuff to be sent to the old fever clinic, and only allow those patients in without either fever or like the history of having a history of having contact with the COVID-19 patients to be allowed to enter for in the outpatient setting. So the pre-assessment and triage becomes highly important in large hospitals. So like we have around 13 patients visiting or doing consultation in the outpatient per day. So that's a large volume and very risky. So the outpatient. So actually, the director for the outpatient department reached out to the simulation center to ask whether we could help them train those the triage nurses, or later they asked physicians to join the triage team to make sure that they have a high quality in the pre-assessment and the triage and the infectious disease triage. So we developed scenarios. Actually, we did our first triage scenario on February 4th. And we did that in the simulation center with all the all the triage nurses that is not on duty or not on call, and we just used that scenario to make sure that everyone is familiar with the algorithm for triage, and later, like I think it's around 10 days later, we run like 3 scenarios in the outpatient setting, or we can call that the in situ simulation if we want, in the outpatient setting to help them understand better on what to do with the triage, and especially when we after the triage, we think that after assessment, we think that the patient is highly suspected as like a COVID-19 positive patient, we have to take the patient to the new fever clinic, and because we would not want this kind of patient to be like to be on the so-called on the loose, to infect more people. So we have to escort or take them to the fever clinic for further assessment. And actually, I think if I can share with you the, I can share with you the, just wait a minute. So actually we have this. So this is we run the algorithm of this with the scenario in the sim center, and we later had a run of the so later we had a run of the scenario. If you can see that this is the outpatient, of our hospital, and I myself is acting as a standardized patient, and the nurse is doing the triage, and we have to ask them to take like a brief relevant history of the patient. And actually, I have to say that the three scenarios we run are being adopted from the real cases that our hospital are taking, because our hospital is actually the 5 of the 3 designated hospitals in the city that actually that actually accept the COVID-19 patients. So that's also a local policy for that. So you see, in this area, we ask them to sit and take the body temperature. We do like an initial body temperature check after they enter with the, if you can see that. So actually, we have like a quick body temperature machine, like a door-like one. But that's very brief, and then we have to ask them to take the body temperature with the mercury temperature measurement. And during that time, they were asked to, they were being asked by the triage nurse about the history, like have you like a history have any contact or been staying in Hubei province 14 days before the onset of the symptoms. So actually, this has been very helpful, I think, for us, because we, for example, so in one of the scenario, the patient is being suggested to be sent to the new fever clinic, and because at that time we are actually running out of the personal protective equipment, so we have to protect ourselves very carefully, try not to have actual physical contact with the patient, so that we can reuse we can still use the same isolation gown without changing to a new one, even we encounter a positive patient. So we have to make like a distance, like 1 meter at least 1.5 meter distance with the patients to avoid any contamination. But during that time, we identified it's very hard to actually keep the distance, and actually we made physical contact. So me, the standardized patient, actually made the physical contact with the nurse while we were going out of the entrance together. the interests of the hospital together. So actually, at that time, I'm acting as a COVID-19 positive patient, and I might have contaminated the isolation gown of the triage nurse. We take advantage of this in situ simulation, and asked actually we ask open questions during the debriefing. We ask them open questions, like, if we encounter this kind of situation, what's the best way we can do to avoid any contamination, or we can follow certain guidelines. So they are being every participant is being very creative, coming up with the solutions, and that's what we did for the pre-assessment triage. So decision making for the triage nurses is the most difficult part, because they are not as trained as the physicians on taking histories. So we have to develop like certain materials or the scenarios to make them to get them familiar with the stuff. And actually asking this kind of questions are very tricky, because at that time many of the populations, they are somewhat afraid to expose that they may have certain contact with the people from Wuhan or people from Hubei. So they try to hide certain things, maybe not intentionally, but this makes the triage a little bit more difficult. So we have to take so we take advantage of those scenarios to help them to actually perform how to speak, or how to ask proper questions, or how to rule out with proper information, and by making those kind of decisions. And I think that's the part from the outpatient. And I think this part is extremely important, because we don't have those community hospitals or community clinics for the general populations to go in and do the triage, or get to know about the patient better before sending them to large hospitals. So the outpatient had to take up much of responsibility to do the trial themselves. And I think that's so far what I can share regarding the simulation. So actually so is everyone okay to see the to see the table? Everyone can see the table, right? So so actually some of the challenges that we face that we face during while we're trying to implement when we are trying to implement the sim trainings, we encounter like we have limited training resources. For this part, we have to reuse all of many of the equipments and the materials. And actually, because we were already running out of the N95 respirator at that time, so we asked all those participants, learners, to take a medical mask, to bring a medical mask themselves and put on the mask first before they were trying to put on the N95 masks. And actually, we were communicating with the hospital leadership, and also those for the infectious control, to try to get more resources. Like maybe those personal isolation gowns or the coveralls that is being expired, but they can still be used in the sim centers. We asked them to send out those to us. We can make full use of them. And so actually this editorial is a collaboration between my institution and my friend's institution in Hunan. The people in Hunan, they were very efficient in providing like the necessary skill training for the healthcare providers. So they used 3 days to develop like a very standardized course in like 60 something qualified instructors. So those 60 something instructors, they help train the healthcare workers in their institutions, and they used, I think, so they used another 3 days, maybe not 3 days, and they used 1 week to train like more than 1,000 healthcare workers in their hospital. Now they have published a book on the necessary trainings on this, like by the end of last month. So that's why I asked them to join in as one of the authors for this editorial. They have much experience on that, but I included their experience in the editorials, which states here. So design, develop the course materials and do fast iterations, because sometimes they also have to have a very homogeneous faculty members that they are being qualified to teach more people, and that basically we do like this kind of training by half day. So half day for a batch of people, and then another half day for another batch. So I think this is a feasible approach for them to provide like a qualified training, PPE training for the faculty members, because their hospital is one of the hospitals for the emergency rescue or emergency reinforcements for in China, to be sent out to different places. So they have much experience on how to do faster iterations and fast distribution of this kind of courses. And we also take advantage of the online system. Like we have the system, we have this called the iLab X system available for them to do certain things virtually, like to do certain procedures in the virtual environment, for them to get to know about the different steps or procedures. And then they only had to come to the sim labs to get trained on the actual stuff, and we save time for them to get know about like the knowledge part as well as some of the skill part. And also we asked our residents to record videos of them doing like hand performing hand hygiene, put on and take off gloves and medical masks. They have to record their own videos and send out to us for us to check whether they are doing this kind of stuff okay. And those who they are not, they have not performed this kind of stuff well. We provide feedback over the internet or the instant messenger to tell them how to do things better, and they provide videos, and they record another video with the proper performances of this kind of stuff. So I think I think I cover the things we do for the intensive care, for the outpatient, and a little bit on the providing them to students and residents. that still need formal training. So, do you think it's time for like questions? Edgar.
Okay. Thank you very much, David. It has been an amazing presentation for your work. I think it will be very useful for everybody here in Mexico. Just let me ask our participants for their questions by the chat, and if they can, maybe they can ask you in English their questions, but please give me just a minute to ask them. Para todos ustedes, muchísimas gracias. Vamos a seguir con esta presentación. Lo que les voy a pedir para que tengamos un poquito de orden, vamos a poner todas sus preguntas en el área de chat. Si la pueden poner en inglés, pónganla en inglés. Si no, pónganla en español y en un momento la vamos a traducir. Si cuando lleguemos a su pregunta ustedes quieren hacerla de manera personal, con mucho gusto les abrimos el micrófono y pueden hacer esa pregunta.
So any question regarding editorial or something that I mentioned just now, I can explain them further.
Okay, David. Unfortunately, many people from other places that not only Mexico, we have also people from Italy and from Spain that they are here in your conference. So they have a question for you. Just let me translate it. One person from Spain is asking us, they don't have a clinical personnel right now because they have a lot of patients in their hospitals. Do you consider that it will be helpful to make simulation activities to prepare the other new personnel, or to wait until the other doctors can come back to the hospital and train them?
So I'm not sure about how actually the system works in the hospital or in their country, but in our institution or in China, we have different batches, or we have different rounds of doctors. So not all doctors are being sent to the front line or take care of patients all at once. We ask some to be saved for like emergency during emergency times. So we have those people that are actually not going to go to like take care of the patients directly, but they will be like in 1 week or 2 weeks time. So we ask them to rest, and also we ask them to come and get trained in the sim centers or other, or receive other kind of training. So that's what we do in China. But regarding their question, I think that's how should I address that? I think that they have to make preparations even before those people coming back or being available to get training, because we have a saying in China that we can prepare but not actually use them, but we can never use something that we never prepare them. We have prepared them for. So we can. So that's our strategy. We have to think of the worst, and we have to get everything prepared. And I don't know if I have answered questions, but I do think that we have to save some manpower to. It's like being served as a buffer to the front line, and while they're being at the buffer status, we can try to help them improve their skills or get them more prepared for the front line. Yeah.
Thank you very much, David. We have a couple of questions. Just let me ask. Doctor Juárez, ¿quiere usted hacer la pregunta o traduzco su pregunta que puso?
Si me hace el favor de traducirla, muchas gracias.
Just let me see. Okay, we have a question from the Dr. Juarez. Dr. Juarez is a doctor that works in Mexico City. He's in charge of one of the largest simulation centers by the National University of Mexico. And he's asking about the ¿qué aceptación se ha tenido en la estrategia en público en general? What has been the opinion of the public in general about the use of simulation to attend the COVID crisis? What have you heard? What have you seen about the people? What do they think about the use of simulation in this crisis?
The general, you mean the general public members of the, so actually we, for the COVID-19, so actually we, I don't think many of the patients or the general public know about what we did for the training, but we do try to share or show them something we did in the hospital. So I think we did post certain things on the WeChat, and so in fact, I don't think that many of the general public knows about what we did. So we are like the heroes behind the curtain. That's also the saying in China. But I do think that when we talk about like when we are like I forgot to mention that during like 2 weeks or 1 month in February, the whole month in February, we only open half day for the outpatient. So, but the morning half of the day of the outpatient department is open. The afternoon part was being shut down. That's being required by the government. But after we reopen those stuff, but after we reopen the full day for the general public, we told them that all those people that welcomes you or greets you for the triage are qualified individuals, and I think that somewhat calms those who actually comes to the patients who actually comes to the outpatient and seek consultation. And also I think the president of our hospital actually mentioned has made a public announcement or deliver a public speech to all the citizens in the all the citizens in the city that we are doing our very best to train the healthcare workers to get them more prepared as one of the measures to make the hospital environment more friendly and more safe for them to come during the outbreak. Yeah, so I think that's a way to encourage, not to encourage people, to calm the people who are in urgent need of medical care and have to come to the hospital around that time. Yeah.
Thank you very much. I don't know if you can see the chat of the in Zoom. So
yes,
other members
I can see that.
are writing the questions. So if you want to answer them, please.
So I see that FJY said, could you share with us what was the initial treatment? I'm not so sure about what the initial treatment means. Do you mean like how to treat the patients? I'm not so sure about the question for this one. The FJR said to everyone.
FJR,
maybe you can make...
si nos puedes aclarar un poquito acerca de si te refieres al tratamiento clínico o a las medidas en simulación, hacer un poquito más puntual la pregunta para que nos pueda responder. If you want to continue with the other question.
Yes, so it's, FJ says yes, so I'll take that as the the initial treatment for the patients, right? So actually, we have so far we have 7 iterations of the guidelines for providing treatments, diagnosis and treatments to the to COVID-19. So for the treatment, we actually just adapt those stuff from the guidelines that our Ministry of Health provided with us. So that's basically like the supporting mechanism and certain things. I'm not actually taking charge of that part, but I can share with you the guidelines. But of course, that's in Chinese. So we are following exactly as what the guideline says, because what we are all very new. Or this virus, the COVID-19 is actually new for every one of us. So I think the national guideline is the only trustworthy resource we can have around that time. Simulation and clinical. So the simulation part, we are more focused on the technical part of protecting ourselves and doing airway management, or this that may be of risk for the providers, and also for the non-technical part, as like the team dynamics, communication. You must understand that after we were most of the time we were the providers were wearing coveralls, which covers everything, and it's of disadvantage for the team members to communicate with one another. Yeah. So I think that's what I can say to FJR and to Rick. Good Lord, so much simulation hospital. My question is how cost benefit is using simulation techniques inside the hospital designed for treating COVID versus using a simulation center. We know that using a real scenario will be very enriching. Okay. I understand your question. So that's a very good question for us. What I can say is that around the time of the outbreak, our ICU is still running, and we cannot afford to risk to make those patients in the intensive care unit to be of risk. So we train the we train the people who are going to take like people in severe condition, those scenarios in the simulation center. So because the sim center is within our hospital, and our hospital is not that huge, so I think it's still okay for people to come, and that's time efficient. I think that's still time efficient. For the cost benefit, cost effectiveness is, what I can say is that we were mostly using the expired stuff, and we were not taking much of the resources. As I can say that as I just said, I said just now that we were mostly preparing those people that actually in the buffer status to get trained. We do not try to mandate those people who are actually doing their clinical work at that time to get prepared. Because during this kind of crisis, the hospital mandates part of the people to rest and get prepared, and not to go to fulfill their clinical duty. But some will have to fulfill clinical duty, and afterwards they take turns to do that, and those people can get some rest and maybe take half of the day to and come to the sim center to get trained. But I do think that running like inside scenarios is the most effective way to do so. and we adjust our debriefing mechanism to save the time. Yeah. We know that using a real scenario could be very enriching for students, but with a high risk. Yes, for the students and the residents, for the students and residents, we ask them to go to the sim centers to get trained. We do not train them in the actual environment. We do not do that because that's being too risky. Yeah, but that's just something that we have to afford. That's something we have to. This is a hard decision we have to make to ask them to go to the sim centers. Yes, impact dissemination among the operating doctors. What's the had an impact of the simulation among the operating doctors and fellows? I'm not so sure about the iPad. The Toro says. I'm not sure about that. So actually, during the outbreak of like the first half of February, late January and first half of February, our blood bank is running out of blood. So storage of blood. So we actually, out of those non-emergency operations were being postponed. So we don't actually have many of the operations running at that time. So we also try to take advantage of that time to get those surgeons or people in that department to get trained. And that, yeah, that's what we do. Yeah. So and then we should not to do for you. So Edgar, you forwarded the big bus. Understand that you did your scenario in the same area of the hospital, is it right? And if so, any reason not to do it in the sim center scenarios? For you, what do you think should be the most useful scenario with which we start at this point of pandemic phase? So for your first question, to doing the sim center. So actually, we still move from the sim center to the in situ environment because we have to ask them to know how to properly do first personal protection first in the sim center, because we do not want the general public to know that we are still trying to train them how to train the physicians or nurses to how to protect themselves. So we asked them to train the sim center, and we had 1 or 2 rounds of the algorithm to get them familiar with the whole guidelines, the stuff in the sim centers, and then we move quickly to the real clinical or the real hospital environment to train them on that. And actually, one of the advantages for doing that in situ is that we can actually identify certain things that cannot be shown in the sim centers because we are using the real working environment, like the setup of the triage, the decks for triage, or the layout of the outpatient, or even how the people coming into the hospital should be lined, and even the should we make changes to the machines, to the self-service machine, this kind of stuff. And as I described just now, that when we are doing the escorting of the patients, the SP accidentally made like a very close contact with the nurse, which we did not identify while we were in the sim centers. So this is something that can really happen in the real situations, a real environment. So that's I consider the in situ simulation as a very powerful tool. And actually, we are going to do like a whole hospital transportation in situ scenario next Friday. So the patient coming into the emergency department and then triage and then going to be transported to the operation room. That's we're trying to we're scheduling for that next Friday. Yeah. So I did not make any kind of video aimed at the people who have relatives at home with coronaviruses, but we have plenty of that kind of resources available by like the public media or other or like the CDCs. So like when we were going on to the subways or the metros, we have those videos, or even on the buses, we have those videos play in loop. So I personally did not, or our hospital did not make this kind of videos at all. Yeah. So what were your assessment instruments, and if you can share with them to replicate? So actually we do have the assessment instrument for the triage and for the ICU part. I can look for that so we actually developed those assessment instruments based on the guidelines. So those are the key the critical points that we ask those triage people to must take in, but we also leave some of the points open because this whole situation is relatively new, and we do not want to limit their creativity. Yeah. So I can share with you on that, and maybe I can share with you guys my email address, so you can send me any further questions on the email, and or any of the materials you require for that. And question from Fabi Serratos: what were your assessments? Okay, that's the same question. So please share the photo with us. You mean the photos I just shared with you, the tri-edge and this kind of stuff? Is that correct? iPad the Alturo or Alturo, right? I simply cannot pronounce that. Sorry, I did not learn much Spanish. Yeah. So question from Roberto: do you have any video to show us a practice of simulation center? In the sim center, we actually did not do the video recording because our sim center did not have shut down the video around that time because I think there's a problem with that. But we did the whole recording for the pre-assessment triage. And actually those videos are actually still on my phone. For the inside two scenarios for the pre-assessment triage, I have that on my phone because I wasn't aware that because actually I'm not actually a staff in the sim center. I work in the general practice. I'm a physician at the general practice, so I'm one of the instructors for the sim center, but actually not the staff for that. So I wasn't aware that they shut down the videos around that time because we were in we were supposed to be in the Chinese New Year Spring Festival around that time. So everything's being shut down. But later, after I know about that, I asked them to do video recordings on the phone. Yeah. Did you develop any kind of airway management strategy for any physiologist? So my friend in the Chinese University of Hong Kong, he had developed like an infographic on certain considerations for doing airway management, and we followed that kind of tips, And actually, I did a Chinese translation for that infographic. I'm not so sure if Edgar has seen that, but I think that's in the resource of that Google Drive that Kristen Park and Jamie Robertson was sharing.
Yes, that's right.
There's an infographic on that. Yeah,
That's
we followed that one.
Yes, just let me do an announcement about that in Spanish so everybody can understand what we are talking about this drive.
Okay, sure.
Para todos ustedes que nos están acompañando, si recuerdan, desde la semana pasada habíamos abierto en la página de internet de la SOMESICS un espacio de intercambio de información acerca del COVID-19 y recursos de simulación. Parte de lo que está comentando el doctor Lee en este momento está en esa carpeta y de todos modos le voy a pedir ahorita al doctor Lee que si va teniendo nueva información o cualquier otro recurso, que nos lo pueda compartir y abriremos dentro de esta carpeta un folder que diga Dr. David Lee y pondremos ahí todo lo que él nos comparta. I'm telling all the members about this drive that we have made in the SSH and about the information that you have shared with us during this drive. And I have shared that information in our website of the Mexican Society for Simulation. So if you can, and I hope you want to share more information with us, I will upload that information in the drive of the Mexican Society for Simulation.
Sure. And I also have a video that that actually my friend in Hong Kong, another friend in Hong Kong that shared with me. So that's a drill or like or in situ simulation that they run in the hospital. So they pretty much covers like the people preparing the ICU room and transportation of the patient from a designated elevator. And then when people are deceased, how to prepare that. And also in that video, they have certain considerations of like they cover all those loose ends of the bag valve mask. They want to make it like a closed system to have nothing to be they do not want the aerosols to be in the open air, so they covered all those connective parts of the bag valve mask. And also they have like a demonstration of doing the section on that. So that's all in the video, the link that I shared just now. I believe everyone can see that, right? It's on YouTube, so everyone can see that. And I think that's a very, very good video, and that's because that's being recorded in Hong Kong, so they have English, certain English descriptions on that. Yeah. Different supplies infrastructure do. In Mexico, so I'm saying I'm reading Ariana Serran's notes. In Mexico, all medical units have different supplies infrastructure. Do you think that simulation should be done for each hospital unit? They ask us to do simulations in hospitals. How do you consider this option? Definitely they should not go to the center because it will be more risk for everyone. Yeah, so for regarding your question, I think if the hospital staff are working within the hospital, they can either choose to go to the simulation center to work to get trained, or if they have enough room and space for them to run in their own units. I think it would be definitely feasible. So actually in one of the hospitals, or actually in the hospital where I get trained in my undergrad, that's the Tongji Hospital. So actually that's in the center of the outbreak. So they actually have a room empty without the medical equipment available there. So they make use of that area to do like a just-in-time training for all the anesthesiologists, and they currently turn that into like a team training facility for all the surgical teams. So that's just within the operation room area, but that's a separate room that has everything. So if you have this kind of resource available, that's definitely a choice for you, or recommendation, my recommendation for you. But I understand that not all hospitals everywhere has this kind of privilege to do that. So if we don't have those kind of stuff available, maybe Sim Center is another choice for that. Yeah, it would be very risky. So during the center of the outbreak, like during like the active phase of the outbreak, we recommend very small group of people attend the course, that attend the training each time. Yeah, as I say, because we have many people in China, so 18 is the limit that I personally accept for all those stuff, kind of training. But for the scenarios, I encourage even less people each time, and we can ask them to record each time, and then they can reflect on themselves even after they go back to their houses and during their rest. Yeah.
Okay, I think those are all the questions that they have right on the chat. Oh no, there is another one from Daniel Martinez.
So Daniel, I'm not so sure about the strategies. Can anyone explain what's the current strategy? Yeah. For Mexican government, I'm not so sure about that. Yeah.
It will be interesting to know about what the other people around the world know about our government strategies, but maybe in another chat.
Okay, yeah. So my understanding for this COVID-19 situation is that like direct contact is more risky than because the virus is not being transmitted via thin air. They have to be transmitted via like certain droplets or things. So I'm not in a very I'm not in agreement that our Chinese government says that everyone should wear a mask, because that becomes a huge problem when the medical staff could not get enough supplies of masks. So, but now the situation is getting better, and we have enough supply of masks, and the government is gradually starting to encourage people not to wear masks in certain circumstances. Yeah, so I think hand hygiene and proper personal protection is more important than wearing a mask. Yeah, and quarantine. Well, if you have a huge amount of population that's being infected, definitely a quarantine or lockdown is useful. But for the rest of the areas, I think we should allow people to have certain kind of like freely, or like to be able to go outside for certain things. And we are actually using the we actually have this code, what we call the so this is a code that shows your status, that is actually showing your status, like how long have you been staying for the same areas. For me, this is the blue this is the blue status. That means
Yeah.
I can go freely, go anywhere I want, because I'm not being considered as being suspected as like a contagious or something. So, but we have approaches of like the red. If it's a red background, that means you are red status. So everyone should be cautious. So the person with the red status should be cautious and seek support. This kind of stuff. Yeah. Yeah, I think there are vaccines being developed, still in development, and they are on trials. Yeah, I'm not so sure because I'm not actually a vaccine person or academic person, so like the epidemiology person. So I'm not so sure about this kind of development. Yeah.
David, there are many members asked me that unfortunately the link that you send us with the YouTube video, it seems that it's not available for Mexico.
Withdraw.
So maybe if you can
Maybe
share me
download it.
another link later, and I can share it in the Dropbox from the Mexican Society, so all of our members can see the video later.
Sure. I can share the videos that actually I have, and see. So we can talk about that like privately, and I see like in persons to see what resource I have available that's actually have English on it, and could be able to share it with you. Okay.
Thank you very much. Let me ask. ¿Hay alguna otra pregunta para el doctor David Lee? Okay, we have another question from Eduardo Navarrete.
Out of the general context of this paper, but I would like to know your opinion regarding controversial medication with treatment. So I think there's, I don't think, from what I read in some of my friends who are actually on this kind of trial, so far there has not been a very positive or like a evidence that's showing like significant effect on that. So I think like the supporting like life supporting, like using the ECMOs of stuff, or like the airway management or like the ventilation. I think this part is currently more important for the people in severe condition, and those that are not in a very severe condition. I think I think it's only a matter of time for them to gradually cure by themselves. Yeah, so that's what I heard from my friends that actually works in Wuhan on that. Yeah. Validation instrument, we don't have time for instrument validation. So that's only the key points that we adopt from the guideline, the Chinese guidelines on the treatments. Yeah. So we do not do any validation. We only adopt the things that's written in the guidelines, and we were trying to ask everyone to follow on that. Yeah.
Thank you very much, David. Just for a closure of your extraordinary presentation, do you? I want to, if you can share us some kind of advice for everybody for the Mexican Society for Simulation, because for us this is a new situation. We have never done this before, so if you can just say something as an advice for everybody will be very helpful, and thank you.
Advices. Okay, so that's a bit hard for me to try to come up with like a sentence or two on this. So I think what I can say our experience is that it's a difficult time for everyone, both in China and of course in Mexico. But I think that if we have more transparency, if we have more like information exchange, like how do you say that? Like more just in time or more information exchange in time or on that and exchange of practices. I think that's that's one of the most effective weapon to fight against the virus, because as more we get to know about the virus and how to deal with the virus, we're gradually become more powerful against the disease, and eventually that's only a matter of time for this to go away, and I think that's so far I can think about, and do count on simulation. Yes, of course. Simulation is very powerful as well. Yeah.
Thank you very much, David. On behalf of the Mexican Society for Simulation members, I just want to thank you for your time. It has been an extraordinary opportunity for us to hear about your experience, and we hope to keep in touch with you and to keep working with the Chinese Society for Simulation in future times. So I just want
that'd be great. Yeah.
I will send you this one by email.
Sure. That would be great. Yeah.
Let me show you. Okay. So this is a letter from the Mexican Society thanking you for your time and hoping that this will be the first of many opportunities to share experience between both countries in order to promote and improve the patient and healthcare personnel safety. Thank you very much, David. And I don't know if somebody from the Mexican Society wants to say something to Dr. Lee. Y si alguno de ustedes gusta darle las gracias al Dr. Lee o dar algún mensaje, en español se vale y lo traduzco ahorita, o lo traduce alguno de ustedes ahorita.
Thank you very much, Dr. Lee. It's extraordinary your work in the China.
Thank you. And maybe I should add one more thing, because many people, many trainees or many of the participants that had participated in the simulation have told me afterwards that they feel more confident, or they have certain kind of relief or pressure because they don't know about the situation before coming to the scenario, but now they are becoming more confident, and they are gradually coming out of the status of like being overflown by the information. It's like they just came out of the shock because there's just too much information on the new information. So they are becoming more, they feel that they are more confident in fighting this, and they have less anxiety after coming back to work. So I think simulation is really a powerful tool. Yeah.
Well, David, you have a lot of messages in the chat.
Yeah, thank you.
And if somebody, si alguien más de aquí de la sociedad gusta decir de manera personal algún agradecimiento, ahorita es el momento. We have a member called Brenda J from Mexico that wants to thank you personally for your work and the information that you have given us to us. And she considered that it has been a very important meeting, and that your experience will be shared in order to improve the safety of everybody here.
Yeah, I think the safety of everyone is so important that this is actually the goal for doing simulation, right?
Gracias, Dr. Lee.
Thank you, Dr.
You're
Lee.
welcome. Welcome. Yeah.
In Spanish, thank you, gracias.
Yeah.
Thank you
So
so much
actually, I
for
only
your
know
time.
I only know like 3 or 4 words in Spanish. One is hola, gracias, and la cuchara. I think that's called la cuchara, right? The fork or something. Yeah, that's the 3 words I know.
You have the basic.
Yeah, thank you.
Thanks,
Gracias.
How do you
thanks for your time.
Thank you.
Muchas gracias,
Welcome.
Dr. Lee.
Yeah, you're welcome.
Fantástica.
¿Qué está haciendo?
Gracias, Dr.
So-
Lee, de Ecuador.
You're welcome.
No.
You're welcome. Yeah.
Well, thank you very much, David, and I hope
Yeah.
to hear from you soon, and we'll stay in contact. Thank you very much.
Okay. Okay. I'll be sending you the videos soon. Okay.
Excellent. Thank you very much.
Yeah.
Thank you.
You're welcome.